Hello and welcome everyone. I hope all of you can hear me. So we are going to start our today's session. And we are extremely thankful and indebted to Dr. SAIRA RAHMAN, who is an FRCR and a consultant radiologist and associate professor at Children's Hospital, Lahore. Dr. SAIRA started her radiology journey in 1990, starting with DMRD training, after which she left for Malaysia, came back, finished her DMRD, topped in the exams. Then she went on her FRCR journey and did it in 2010. She has immense experience in pediatric radiology and has also done attachments in NHS UK before giving her exams. And so we are really thankful, Madam, that you are sparing us our time and we are tuned in for a great radiology session. To you, Dr. SAIRA.
Okay, thank you so much, Sabahat. I hope everyone can hear me loud and clear.
Yes, we can.
Okay, thanks so much and thanks for the wonderful introduction. I'm really grateful to you all for asking me to conduct this class. And hello, everyone. So should we start, Sabahat?
Yes, we can start, Madam, and I will go first as the hot seat candidate.
Okay. Okay, our case 1 is a 9-year-old child with history of trivial trauma.
Okay, Madam. Okay, so this is the frontal chest radiograph of a 9-year-old child with history of trivial trauma. I can see that there is a fracture of the right clavicle in the mid clavicle part with distracted and actually overlapped fragments. There seems to be a degree of periosteal reaction and callus formation, which indicates that this is not acute. I'm now looking at the adjacent, the left clavicle, the scapulae, and the ribs, trying to look for any other fracture. I'm failing to see any. So in this 9-year-old child, I would ask the parents regarding any previous history of trauma, and a trivial trauma should not lead to this clavicle fracture. So either this is due to his metabolic deficiency, which has led to this fracture, or if the history does not match, I would be suspicious of non-accidental injury and would order a skeletal survey.
Okay, this was the first time the child had this fracture and the trauma history. Anything else you can see? Like you said, like there may be another cause in bones.
Yes, the bones look, when I look again, they look a bit dense. So the density appears to be increased. So I'm thinking if this patient has the disorder of the phosphate metabolism or fluorosis, so I would be thinking regarding having a metabolic profile for this patient if possible.
Okay, so we go to the next case.
Okay, ma'am.
So this is a 12-year-old with multiple joint pain.
Okay, madam. Okay, so this is the frontal pelvic radiograph of a 12-year-old with multiple joint pain. I'm comparing the right and left hip joints. It seems that the right femoral epiphysis to be a bit denser than the right, than the left, sorry. In fact, if I may take back, I think it's the reverse. It's the left femoral epiphysis which seems to be decreased bone density, and the acetabular region also seems to be a bit sclerosed on its superior aspect. The joint space appears relatively reduced on the left side, I'm wondering if this patient, I would ask if there is any previous radiograph for comparison, and ask clinically if the patient has pain in the hands and other areas to image those joints as well, with the possibility of juvenile arthritis, idiopathic arthritis in a young patient. Septic arthritis, I'll put it less likely because it would not have presented with multiple joint pains. So a discussion with the clinician, imaging of other joints, and referral to pediatrics rheumatology for further management would be my next steps.
Okay. These are the radiographs of other joints and the skull as well.
Okay, madam. So I have been given the AP and lateral X-rays of the skull, which demonstrates multiple lucent areas with narrow zone of transition, and a few of them show clearly beveled edges. I'm also provided with frontal radiographs of what I believe elbow and the knee joints. There I can see that there are again lucent areas and joint space narrowing in the elbow, and in the knee I can see a sort of permeative pattern in the proximal tibia. So putting all these findings together, eosinophilic granuloma comes to me as a prime possibility, which would be a musculoskeletal metabolic bone disorder, which would lead to such appearance and secondary joint pains.
Any differentials you would want to
Yes. Other differential could be, this is a child. So I wouldn't put myeloma as a possibility. A metastases from unknown primary like neuroblastoma could be a possibility. If the patient has a renal pathology, renal disorder, so long-term renal pathology leading to brown tumors, perhaps. That's what I can think of at the moment.
Okay. So the next case is a 1-year-old child with abdominal distension.
Okay, ma'am.
Okay, I'll go to the
Yes, ma'am.
Case. Okay. So can you see this?
Not at the moment, madam.
Okay, now.
Yes, it has started screen sharing. I think the image is now here. Yes.
Okay. Should I scroll for you?
As you wish, madam.
Okay, you can start with your description.
Okay. So this is contrast enhanced CT starting from the neck. I can see that there is sort of soft tissue density in the orbital areas. And there is periosteal reaction along the jaws, along the mandible with lucent areas. Multiple, as we scroll down and going to the chest, I think there are multiple lymph nodes, axilla, there is bilateral pleural effusion. I take back my words. This is non-contrast. This is plain CT. So bilateral pleural effusion, axial lymph nodes, going down to the abdomen. So I can see that there is a soft tissue density in the midline in the abdomen with few faint specks of calcification. This is actually multiple. It is, I can see that it is clearly encasing the vessels and lifting it. This is causing gross displacement of the adjacent bowel loops as well. So in a pediatric patient with a soft tissue density, soft tissue mass in the region of adrenals crossing the midline, foci of calcification, ascites, and periosteal reaction generalized throughout with multiple lucent areas, I would be thinking of neuroblastoma as my prime possibility. And in my routine practice, I would proceed to contrast enhanced imaging for further evaluation. So now I've been provided with contrast enhanced imaging of the abdomen. I can see that there is soft tissue densities in both the orbits, again, re-demonstrated the sunburst periosteal reaction in the mandible, multiple lucent areas, going to the multiple cervical lymph nodes. And now as we move to the chest, there are axillary lymph nodes, pleural effusion bilateral, extensive pleural effusion bilaterally, which is causing collapse of both the lungs. In my routine practice, I'd also look at the lung windows. Coming to the abdomen, I can see that there are multiple hyperacute lesions in the liver as well. And as we go down to the abdomen, I can see again the soft tissue density lesion with few areas of necrosis encasing the vessels. There is a focal lesion in the spleen as well. So I can see clear encasement of the vessels with stretching, however, no filling defect noted. So this is clearly a case of neuroblastoma. I would inform the clinician. An MIG scan can also be done if required. And the patient would be referred to pediatric onco MDT / surgery for a multimodality management in this patient.
Okay, and we will also do the urinary analysis, right? For
yes, a urinary analysis for the catecholamines, yes.
Yeah. So we come back to the next case.
Yes, ma'am. So this is a young child
involved in RTA previously.
Yes, ma'am. So this is the AP and lateral radiograph of the left femur in a young child who was involved in RTA. What I can see is a deformed morphology of the femur, along with loss of communication between the femur head and the body. Actually, the neck seems to be resorbed. There is extensive calcific foci along the whole length of the femur. There is also lucent serpiginous areas within the distal femur. Seems to be associated soft tissue thickening. I'm thinking of two possibilities. I would consider as post-traumatic myositis ossificans if the patient is asymptomatic. However, if there is a history of recurrent sepsis fever in this patient, and with this morphology, I would also consider chronic osteomyelitis with involucrum and sequestrum formation and cloacae formation, repeated episodes as the other possibility. I would compare with the previous, and considering the inflammatory markers and the clinical suspicion, I would communicate with the clinician and refer to the pediatrics.
Yeah, anything else you could do for this patient?
I think if we are considering myositis ossificans, and if the clinician with the discussion they need it, we can do a CT maybe to reconfirm. But however, comparison with the previous and the clinical history, I think it should be, it should suffice.
Okay. So the next case is respiratory distress in a newborn.
Yes.
This is a topogram, I know, not very clear, but we can still see the pathology in it.
True,
right?
ma'am, true. So this is the scout of the CT chest and abdomen of a child who's presenting, neonate, I believe, newborn, presenting with respiratory distress. What I can see in the topogram are, madam, the topogram went away. In the topogram, I can see lucent areas, air-filled in the right hemithorax. In fact, there is loss of definition of the diaphragm. So I think I would keep a congenital diaphragmatic hernia as my prime possibility. And I would inform the clinician, because this causes respiratory distress and pulmonary underdevelopment in the child. And a CT axial cross-sectional imaging would help.
Okay, so would you consider some other diagnosis?
Yes, the other differential in this case would be a congenital pulmonary airway malformation. In that case, we won't be able to see the diaphragm. We would be clearly able to delineate the diaphragm. So the differential is between congenital diaphragmatic hernia versus congenital pulmonary airway malformation, or what we call CCAM.
Okay, good. So I'll scroll through for you. Wait, let me put the lung window for you. Okay, sorry for the delay.
Yes, no problem.
I scroll through, huh?
Yes, ma'am. So these are axial CT chest in lung windows. I can again see cystic lucencies occupying a major part of the right lung. I think I can then see preserved lung parenchyma in at the caudal part of the right lung window, and diaphragm appears to be maintained. So I think I would consider in this patient as a case of congenital cystic adenomatoid malformation, and discuss the case with the pediatric and refer it to pediatric thoracic surgery for management.
Hi, Dr. SAIRA. Sorry to interrupt. It's 15 minutes now. Over.
Okay, okay. So the next candidate?
Okay, madam. The next candidate is Dr. Karthik. Let me just see. Yes.
Should we go through these images?
Yes, madam. Yes, madam. That can be also a good option.
That is better, I think.
Yes.
Finish with these first.
Yes.
Okay. The first one, as you said, there is increased bone density, and of course, this is clavicle fracture. So osteoporosis is another differential in children, which is very important. And history of trivial trauma giving this fracture in brittle bones. Remember the marble bones of children. Okay, this was another hand of the patient arm, sorry, and this was another fracture through it. You can see the vertical lucencies along the metaphysis, and these are the typical bone within bone, the sclerotic base of skull and all that, right?
Yes.
And the angle of mandible is important. You can see the angle of mandible, and this was osteoporosis, right?
Right, madam.
Okay, multiple joint pains, as I told you, this was a large lesion there. It is mixed sclerotic and lucent lesion, right? It is all in the iliac bone and the acetabulum, not involving the head. And so, of course, then we rule out the possibility of septic arthritis, right? So, in multiple joints, okay, you very good, rightly asked for other images. These are the typical beveled margins of Langerhans cell histiocytosis, eosinophilic granuloma, as this patient was diagnosed. And what I usually do is I ask for the skull radiograph when there is when there are such lesions, and many times, we have diagnosed on these typical appearances, and of course then bone marrow and all is done. So the lesion here also, and of course here also in the metaphysis of long bones.
Yes, madam.
The next is this one. This was very rightly and nicely described by you. This was neuroblastoma, and this was stage 4, as you could have told me, with mets in the liver and bones.
Yes.
And we could also see the iliac crest with the speculated
margins.
True. And this is the differential Wilms tumor. As you can see, it is a bit well circumscribed, right? It is also crossing the midline and displacing the vessels, not encasing as we see in neuroblastomas, right?
Yes, ma'am. Yes.
Okay, this is osteomyelitis, right? The whole bone is involved. You can see this nail as well. And there was fracture, subcapital fracture, which caused the displacement of the bone towards the upper outer side. This was a nail which was displaced because of the osteomyelitis and the bone being soft. And this is all involucrum, the dead, the involucrum there, the dead bone, the sequestra, and this is the cloaca formation over there, right?
Yeah.
And you can see that the fat planes are blurred. Right?
Yes.
Which happens in infections. So we could do an ultrasound or a CT scan. Ultrasound is a very handy tool in children for any collection of fluid, which we can tell the surgeon to drain. And of course, we will send this patient to the surgeon for debridement of bone and nailing or whatever treatment he wants to give, right? To save his limb.
Understood, madam.
So respiratory distress, very rightly said, a CCAM. The differentials are, this is another CCAM, diaphragmatic hernia, no bowel in the abdomen. And you can also say that these cases are associated with diaphragmatic hernia, with chromosomal abnormalities, with cardiac abnormalities, and we would, assess for that. Then this is another diaphragmatic hernia. This is eventration, which is another differential of such cases, right? There is displacement towards the other side. We can see the diaphragm. Over here, we could see the diaphragm. Huh?
Yes. Okay, madam.
Yes. Huh?
Yes.
Okay, good. Okay, this is the next.
Okay. Dr. Karthik, I've got two Dr. Karthik. So, Dr. Karthik, is this you? I've made you a co-host.
Yes, I'm.
You are the right one?
Yes.
Okay. Over to you. Thank you, Dr. SAIRA. Wonderful cases. Thank you so much.
Okay, you did well, Sabahat. You did well.
Thank you, madam.
Descriptions and everything were very good.
Thank you, madam. Thank you.
Okay, so this is, we start with the next candidate, 5-year-old child with constipation and abdominal pain. History is always very important. Remember that.
Okay, this is a frontal radiograph of abdomen in a 5-year-old child presenting with constipation and abdominal pain. Sorry, I'm able to see dilated bowel loops predominantly and few dilated bowel loops and no hostel and there is no rectal gas. I'm able to appreciate in this X-ray, and there is a diffuse granular opacities in the right lower quadrant of the abdomen. No, the small bowel loops up. I can see few small bowel loops in the right side of the abdomen. And since it is a 5-year-old child presenting with constipation and they're not able to see the rectal gas shadow, I'm thinking of Hirschsprung's as my primary differential, and I would like to proceed with a contrast enema for this patient for further to take this case forward. Okay, these are the contrast enema of the same patient. You can see there is a gross dilatation of the sigmoid colon and with the reversal of recto-sigmoid ratio. And I also see a small focus of narrowing or at and the descending colon. So these findings are in keeping with the Hirschsprung's disease. There is also multiple fecal pellets noted within the distended sigmoid colon, going with the constipation history of the child. I would convey the findings to the referring pediatrician and advise a rectal biopsy for accurate diagnosis of this patient.
Okay, very good. Can you tell me which segment of bowel is abnormal?
Actually, I can see
No, what I mean to say is there's some narrowing, there's some enlargement. So which part of the bowel is actually the abnormal part?
The actual part is the dilated part is the aganglionic part. The sigmoid here in case.
Okay, we'll come back to it again. So these were the lateral views, right?
Yes.
Okay. The other case is a 4-year-old with increasing nasal swelling. Huh?
Okay, these are multiple axial sections of the CT brain in post-contrast images in a child with nasal swelling. In the sections of the brain, I'm able to see there is a colpocephaly, dilated ventricles are noted on both hospital horns of both ventricles appear little dilated and widely spaced, and in the coronal images in the lower row, I'm able to appreciate there is a defect in the anterior base of the skull with a soft tissue protruding in through the anterior base of the skull into the nasal area, and also some cystic component into the soft tissue more in the left lateral aspect. So with this findings, I'm thinking of an anterior nasal or and colpocephaly can it be a syndromic? I'm just looking for any other syndromic associations. So just a 5-year-old with okay, this is a case of antimeningos, sorry, it might encephalocele because I can see that there is a herniation of soft tissues. In my routine practice, I would like to see even the brain window images to confirm there is there is actual herniation of the brain tissue through the base frontal defect.
Okay, and what about the colpocephaly that you mentioned?
This colpocephaly can be seen in case of any partial corpus callosal agenesis or so. Yes. Yeah, so I want to look at it would be great if I can look at the corona SAG images or corona images.
Okay, good. Good.
I would inform the findings to the for a neurosurgical evaluation.
Yeah. Okay. So the next case is repeated cough and fever. Huh?
This is a frontal radiograph of a child with repeated cough and fever. I'm able, the striking abnormality that I'm able to see is air lucency projected over the left cardiac margin. The left with some septation in between, I see and I'm not able to appreciate the left cardiac borders clearly. The left hemidiaphragm is obscured. I don't see any pleural effusions. The rest of the lungs appear normal. So in a child with repeated infections and in a left lower lobe lesion, I'm thinking of the possibilities here. I'm thinking is it a diaphragmatic hernia or a congenital sequestration? So I would like to proceed further with a contrast enhanced CT of the chest for further evaluation.
Okay. We did a lateral for this patient.
Okay.
You know, always the simpler things first, right?
Okay. on the lateral view, yeah, I'm able to appreciate both the continuity of, anteriorly in the retrosternal area, I can see the gas shadow that is seen extending from the abdomen into the thorax. Posteriorly, the diaphragmatic continuity is maintained. So this is more in keeping of with an diaphragmatic hernia, more likely a Morgagni type, which is anterior. So
okay. You asked for CT scan, so here's the CT scan as well.
yeah.
Huh? So
This confirms our findings of a diaphragmatic hernia. I can see the bowel loops extending into the thorax.
Okay. Anything else also in the lungs you can see in this CT
Lungs.
scan?
Yes, I mean there is a overinflation of the right upper lobe, hyperinflation, or there is mosaic attenuation in the right lung parenchyma, but is it right side hyperinflation? I think there is hyperinflation.
Okay. So anything that comes to your mind in a child with one congenital lesion and the lung, on the other hand, is also like hyperattenuated with fewer vessels.
Can it be a congenital lobar emphysema needs to be ruled out in this?
Okay, that's great. So this case is a 6-year-old girl with right upper chest pain. Huh?
Okay, this is a frontal radiograph of a 6-year-old child showing the chest, abdomen, and pelvis. So I got the markers. Sorry. This abnormality I'm able to appreciate is a displaced fracture in the right mid clavicle, and also there is I think there's an old fracture in the left mid clavicle with some callus formation. Then along the left humerus distal aspect, there is some periosteal reaction, uniform periosteal reaction. Then, so in a child with multiple rib fractures and some of different ages, my primary differential would be a non-accidental injury that I would like to rule out. So I'm looking for, in a systematic way, I'm looking for other bones or any other metaphyseal corner fractures or posterior rib fractures. This I don't appreciate any other rib fractures. Let me just no, I don't see any rib fractures or any other metaphyseal corner fractures along the usualized bones. No.
Okay, so what do you do for this patient?
So I would
Now
like to
just
proceed
suspicion?
further with a skeletal survey for this patient, because
and there were no other fractures then. Now you see these
then a metabolic survey would be essential for this patient to rule out any primary bone disorders like
do you see any other like basic bone abnormality in this patient? Do you the bones, rest of the bones, they appear quite normal.
The ribs are slightly broad actually. No, it's a false positive finding, I believe. The bone density appears okay. Is it
so your suspicion was
primarily I was thinking of a non-accidental injury, like
so what would you do? You see, if you are suspecting an NAI, so what is the next step you would take?
I would inform the referring physician about the findings immediately, and then proceed for a skeletal survey for detail for including the skull and other limbs.
Okay. Sorry, I put that with the touch. This thing, the arrow came up.
No problem.
This is a 5-year-old with multiple swellings on head and now presented with headache, right?
Okay, this is a frontal radiograph of the skull. I can, sorry, I think I'm not able to appreciate the orbits. It's a projection is little, I think it's a problem with my intent. No problem. In the right, to the right of the midline in the vertex region, I'm able to appreciate a soft tissue in the extracranial soft tissue swelling. I'm looking for any underlying bone defect. So the underlying bone appears slightly irregular, but I don't see any obvious defect there. I would like to see at the orthogonal views if possible. Any lateral view is there or okay. Yeah, here able to appreciate like a spiculated appearance of the frontal bone there, underlying the swelling, extracranial soft tissue swelling. Looking at the rest of the bones appear normal. Is it? I think the slightly hyperdense. The base of skull appears slightly hyperdense. The sella appears normal. The rest of the jaw, I'm looking at the mandible. So the dentation is slightly abnormal. I think it's their supernumerary teeth are there. Okay, the sinuses appear normal. Okay, so in a child with multiple swellings and with head swellings, I'm thinking of any my primary differential. I would think of any metastatic process that is going on, or with the speculated appearance, even thalassemia is like a possibility with like a hair on end appearance of the skull. But the sinus appear normal, not in the appear uninvolved for thalassemia, so that goes against it. So I would like to proceed further with a cross-sectional imaging or any pertinent history for the patient. Okay.
So a CT scan was done for this patient to further assess.
Okay.
Because remember, the patient has headache also now.
Oh yeah. So I can see there is the visualized the soft tissue swelling that we visualized on the radiograph is seen both. It's seen extending intracranially also. There's an intracranial component, both along involving the entire frontal bone and the right parietal bone. There is this soft tissue thickening is causing mass effect on the underlying right cerebral hemisphere with some vasogenic edematous change there, underlying brain parenchyma. That shows gross speculated changes. So with a bony change with bony changes with soft tissue swelling on both sides of the brain, I would be thinking of more of a metastatic process in a child, and neuroblastoma would be my primary differential. And
okay.
Like to do a cross-sectional imaging of the chest and abdomen for further evaluation.
Okay.
Okay. These are the axial images of the chest and abdomen. See in the mediastinal soft tissue window. I'm seeing right paravertebral soft tissue lesion extending to the right hemithorax with a speck of calcification is also noted. It is extending along the paravertebral region up to the level of just ending above the level of the carina. I'm able to look for any intraspinal extension, which I'm not able to appreciate on these images. Coming to the abdominal sections, the bladder appears distended. Is there any bone looking for?
Madam, sorry to interrupt. Just to let you know that 15 minutes are up. You can wrap up the case.
Okay. Yeah. Very right. You give me the diagnosis then.
It's I think with the calcification paravertebral, it's a neuroblastoma is a primary differential I'm thinking of in this patient. Yes. Or
with multiple metastatic
along the
parasympathetic, get the work done.
MIBG scan would be indicated for further staging of this patient.
This is the speculated periosteal reaction, as we saw in the previous case. Also, the neuroblastoma of left suprarenal region also had this speculated periosteal reaction and metastasis in the iliac bones. And very rightly, you said there's compression on the ipsilateral lateral ventricle and midline shift, which is also very important to tell. And yes, there is vasogenic edema. These are extraaxial masses, right? We must say whether intraaxial or extraaxial. And when they are surrounding the bone on all sides, then yes, they are arising from bone. You can see the separation of sutures. You know, this is another thing that indicates that these are neuroblastoma mets, right?
Oh.
And this was rightly done. Sorry, this thing came up and you saw all this. This was a battered child, of course, NAI. This was also rightly done. This is, yes, partial agenesis of corpus callosum, colpocephaly, and you see the parallel orientation of the bodies of lateral ventricles. You see, otherwise they are not so parallel and straight like this, and they are further apart from each other. And you see the interdigitation of the sulci in the midline. So this was agenesis of corpus callosum with encephalocele. This is cribriform plate defect, right? And there is, you can clearly see these. I purposely didn't put the brain tissue window. You can see the herniation of brain tissue and the meningeal fluid. So this was meningoencephalocele of through the cribriform plate. Okay, this was also rightly done. And one thing which I want to tell you, the abnormal segment in this case is always the narrow segment. This is just a contraction. The dilated part is the normal bowel. The aganglionic segment is the narrow part. This goes into spasm, and to overcome this, the gut keeps on increasing its movement and it gets dilated. And this is actually the ganglionic normal part. The ganglion cells descend from the proximal to the distal. See, and whenever they are arrested, then this happens. This is a short segment, right? There are 4 kinds of Hirschsprung disease, and you rightly told about the rectosigmoid.
Ma'am, one doubt, ma'am. In the previous case, was there any other segment of narrowing in the
this one?
In the descending colon up? Yeah,
this
there.
one?
Yeah.
No,
Yeah,
this is, I told you, this is a contraction. You see,
contraction.
if you have other views, then you can always see whether this contraction opens up or not.
Okay.
Right?
Okay. Yes.
This is actually a contraction. And on the plain film, you were very right. This is a part of the sigmoid colon. And this mottled appearance is always the fecal matter mixed with air, right? Yes. So this is dilated bowel due to the Hirschsprung. I think that was it, right?
Madam, should we keep the question answers at the end of all the hot seats?
Okay.
Or can we ask in between? I know I'm asking, what will be your preference?
Like when we finish a session, if you have a question, I think you should let me know.
For the session 2, we can ask you questions?
Yeah, sure.
Okay. So there has been a question, first of all, that in Hirschsprung, should we do a 24 hours film?
Yes, a 24 hours film is required when we are not sure about the diagnosis. That is what our routine is, right? When we see this, and this is like typical Hirschsprung, and this lateral case, this is another case, in fact, right? This is the one which we, the AP of which I showed you. This is another case. If sometimes, and many times this happens, that the history is very typical, and the surgeon has, when they do a PR for this patient, there's gush of stool coming out, and when this happens, they have a very strong suspicion that it is Hirschsprung, but we don't see it on the barium enema. It looks like quite normal. Those are the times when we do the 24 hours film. And if there is retention of barium, then you know, we also give the suspicion, and then we have to definitely go for the rectal biopsy, because there are sometimes these distal rectal segments, very short segments, which are involved, and we can hardly see them on barium enema. And when the child is small, then we don't see such big dilatations, you know, when the child presents with like severe constipation after birth, and we can't see the narrow segment, then we do the 24 hours film to confirm our findings, and then we tell the clinician that there is retention of barium and he should go for the biopsy.
Okay, madam. There's another question regarding the I think the neuroblastoma, that should we do MIBG and bone scan both? As the book says, the textbook says that 30% of neuroblastomas can be missed and not picked on MIBG. So should we do both, or in exam
Yeah,
setting,
I
we
think
just
that
say?
is what is the recommended thing, that bone scan has to be done.
Okay.
Right, bone scan
Yes.
has to be done. And Sabahat, in this case, like in the stage 4 that we saw both cases,
Yes.
this is so obvious.
Yes.
The stage 4 is so obvious that I sometimes feel that, you know, overburdening the patient and the departments for such cases. What more information will we get from MIBG scan when we
True.
already see this bone metastases and all?
Right. Another question, I think, which you have explained, that how to differentiate contraction from the aganglionic segment, and you said to look at the other films
Yes,
of the
yes.
of this slide. Okay.
Yes, that is true for all contrast images.
True.
All
True.
contrast studies, right?
Yes.
That is true for all contrast studies. Many a times the PG will come that, oh, there is this narrowing, but I tell them, look at the second image. There's nothing in it. It has opened up.
Yes, madam. Totally understood. I think we can go to our next candidate. And madam, you know, the question you asked about the Hirschsprungs, which is the abnormal segment, took me back to the FCPS residency days. We make this mistake so often.
Yes.
Which one is the abnormal segment? Every time.
I always ask my students, and in the exam also I ask them.
Yes, yes.
Very right.
Thank you so much, madam. Our
Thanks
next candidate. Yes, sorry, go ahead.
No, thanks a lot. Thanks for the time.
Dr. Harun, you are next.
Assalamu alaikum.
Wa alaikum assalam.
Okay, so this is our next case, I believe. Crying infant with distended abdomen, right?
Right. So I have been provided with abdominal radiograph of a crying infant with distended abdomen, and the striking abnormality is the distended bowel loops, which I can appreciate, and these are I can appreciate that some small bowel loops are also distended, which are present in the center of the abdomen, and large bowel also appears to be distended, and I'm looking for any ischemic changes, and I cannot clearly appreciate any pneumatosis, but I'm now looking at any gas lucences which are present over the liver. I cannot clearly appreciate any lucences, and apart from this, I can also cannot appreciate any clear rectal gas. So there's no obvious free intraperitoneal air as well. So overall, summarizing my findings, there are multiple dilated bowel loops. I am worried about bowel obstruction, and so in a neonate, and this could be due to a Hirschsprung disease, and or I cannot appreciate any other abnormality obvious. So I would urgently convey my findings to the referring physician, and patient needs a referral to the pediatrician, and as well as if there are any other views available, and lower GI barium study as well to further confirm my findings.
Whenever you see obstruction, a bowel that is obstructed, would you like to look for other things which would cause the obstruction? You know, usually the examiner will show you a film which will have the cause then and there for you to see.
Yes. And now I'm looking again for any cause. This is a neonate. I'm again looking for any obvious abnormality. So I can now appreciate that there's some air lucences which are present in the right inguinal region. I'm a bit worried about some inguinal hernia. This could be due to some inguinal hernia, as some lucencies can be seen in the right inguinal region.
Okay.
I would be worried about inguinal hernia, which is strangulated and causing upstream bowel obstruction. Again, for any, I'm also looking for any other cause like anal atresia, but I cannot rule out completely on this film. So again, I will urgently convey my findings, and as this is an emergency condition of bowel obstruction, so patient needs further imaging to rule out the cause, and urgent pediatric surgery
What
referral.
further imaging would you do to rule out the cause? If you are suspicious of this,
Yes.
right, inguinal hernia.
This could be
What do you think?
an
What
ultrasound
will
scan.
help you in the department?
Yes, ultrasound scan
Yes.
can be done, as this is a
Okay.
neonate. So that can be performed of the right inguinal to confirm my findings. Further, if there is a concern for anal atresia, then a lateral projection film can be done, or an ultrasound of the perineal region can be performed to further confirm the findings.
So on this film, would you choose one of the two differentials that you mentioned?
Inguinal hernia leading to upstream bowel obstruction.
Okay. Next case is a 1-year-old child with cough and fever.
Okay. So I'm looking at the CT thorax lung window of a 1-year-old child who presented with cough and shortness of breath. I can appreciate that there are multiple, the striking abnormalities, multiple bilateral small lucencies which are present in the bilateral lung fields. And apart from this, I can also appreciate that there is a significant bilateral patchy ground glass haze, as well as peripheral consolidation present in the, especially in the right lung. So apart from this, I cannot appreciate any pneumothorax or pleural effusion in these images. So overall, summarizing my findings, the bilateral cystic lucencies along with ground glass haze and peripheral patchy consolidation are more in favor of some infective process in this young patient. And I am thinking that as the lucencies and some infective process are more pronounced in the apical region as well, mid as well, I cannot clearly appreciate the basal regions. This could be due to cystic fibrosis leading to infection, as some cystic lucencies are also seen. So this could be due to a cystic bronchiectatic changes, but and this is a young child, so I would urgently convey my findings to the referring physician and discuss with him. If the inflammatory markers are raised, then this is more in favor of infective etiology. And also I would like to see any previous imaging if they're available. And
okay, the previous imaging also showed these lucencies, these small cysts in the lung, but the opacities were not there. Okay.
So okay,
so anything
I'm
that clicks to your mind? You see, this patient now had fever and cough. Okay?
Yes, definitely now it's a super added infection on the background
what underlying
of
condition can you think of in a child with cystic lung disease?
This could be a CPAM, which but there should be these are very tiny and bilateral. So further, I cannot clearly appreciate any other abnormality.
What cystic lung diseases do you know of in children?
There could be a CPAM, cystic, and as well as there could be or cystic. At this time, I cannot clearly
Okay, we'll
remind
come back
any.
to it, right?
Yes.
We go to
Yes.
the next one. It's okay. Your description was very right. Okay, painful swelling of finger. Huh? Next
Right.
case.
So I have been provided with a radiograph of the hand. I can appreciate that patient presented with the history of painful right hand. There is a liticlian which is occupying the proximal shaft of the index finger, and it is I can appreciate that it is associated with significant surrounding soft tissue swelling as well. And the other striking abnormality is that the length of the index finger is also short as compared to the other fingers. And apart from this, I cannot clearly appreciate any other abnormality in other fingers. So as this is a young child, and so I'm more worried about tuberculosis, as this could be my provisional diagnosis could be a spina bentosa. Tuberculosis causing this lesion, and other differentials could be this could be, as this is a young child, so LCH is also eosinophilic granuloma is also in my differentials. So I would urgently third is the metastasis from an unknown primary, or so I would urgently convey my findings to the referring physician, and would recommend that if there is a history of any known primary, then this would be a metastasis. And further, if there are any other joint pains, then I would also want to recommend a skull X-ray to look for this lines. So if there is any other joint pain, then I would also like to see the skull X-ray to rule out any other lesion. And so this patient needs further.
Okay, we'll come back to it. You mentioned the diagnosis in your differential. Okay. So 4 months old infant with repeated chest infections.
So I can appreciate that I have been provided with a frontal projection chest radiograph of a child who presented with repeated chest infections. The striking abnormality in this radiograph is a opacification which is overlying the mediastinal region. And now I'm closely looking for this abnormality. So as this is a 4-month-old child, so I'm also thinking about some thymic shadow. I'm looking for any other abnormality as well. I cannot clearly appreciate any lung abnormality. Right lung also appears to be unremarkable. There's no pleural effusion or pneumothorax. I'm now systematically looking for any bone abnormality. So I cannot appreciate any rib erosions. Apart from this, I can now, if I'm looking again, I can see that there is some erosion of the bone as well in the left chest wall. Some periosteal thickening is also appreciated in the chest rib, left chest wall and posterior ribs. So
okay, let me interfere over here. If I tell you that this was your chest session going on, then redo your description. Just describe what you are seeing.
So I can appreciate that there is irregularity of the left ribs, left chest ribs, and these are the posterior ribs. I can appreciate that 1, 2, 3, 4, 5. Well, left, 5th, 6th, and 7th rib are slightly irregular.
Okay, let's come to the lungs. Let's come to the lungs. This is a chest session going on, not a bone session. Let's come to the lungs.
Right. So I can appreciate that there is a slight mediastinal shift towards the left side as well. And I cannot really appreciate the right heart border. So as the right lung appears to be more hyperlucent as compared to the left lung.
Good. Yes.
So I'm worried about some foreign body aspiration can be cause this thing, like, but the child is small, so I'm thinking about some congenital lobar emphysema as well. And other causes could be this. I cannot appreciate any chest wall abnormality to call Poland syndrome. So I would urgently convey my findings to the referring physician. And as the patient requires the further evaluation with the CT to confirm my findings. So I've been provided with a CT scan of the same patient, as clearly appreciated that the right upper lobe of the right lung appears to be more lucent as compared to the rest of the lung, and there is also contralateral shift of the mediastinum as well. So I'm consistent. These findings are consistent with congenital lobar emphysema, leading to contralateral shift of the mediastinum as well. So I would again convey my findings to the referring physician, as patient needs further discussion in the pediatric MDT regarding management.
Okay. So the next case is a 6 years old with chest infection.
Right.
Madam, 30 seconds left.
So should we just go back, right? We
I
can
guess
see
so. Yes, we can have the
the
feedback.
next candidate.
Yeah.
Okay. So this was CLO.
Yes, yes.
Coming back to this X-ray, okay, even if you can't appreciate this at the first, because maybe you've not seen so many CLOs,
Yeah.
but the mediastinum is shifted towards the opposite side. You can see the anterior junctional line also shifted. You can see this hyperlucency in the right upper lung and mid lung, and the rest of the lung appears compressed, right? And the
Yes.
left lung over here is normal. So this is the typical attenuated vessels, hyperlucent right upper lobe, mediastinal shift, anterior junctional line shift towards the opposite side. So pneumothorax would of course be totally devoid of lung markings, and this was CLO.
Okay, thank you.
And very rightly said, tuberculous dactylitis or spina ventosa, it was called. And once upon a time, syphilis was a differential, because that also had a similar appearance. Yes, LCH it can be, but metastasis a bit rare below the elbow. That is what our teachers used to tell us long time ago, that metastases below the elbow are rare. Whenever we say metastases in bones below the elbow, we can, it does happen. I'm not saying it doesn't happen, but they are rare, right?
Right.
And in children, metastases could be, bone metastases could be from like only one lesion, and then from, if they're from neuroblastoma, or if they are from HCC or Wilms, there would be other lesions probably, and there won't be a single lesion going to the phalanges more often, right? So
Right.
this
Thank you,
was
ma'am.
spina ventosa, as it was called, right? And this was cystic lung disease, and this was LCH, right?
Yes, ma'am. Right.
Patient, purposely I didn't tell that this patient was known LCH, and now presented with cough and fever. And you very rightly mentioned these peripheral ground glass haze and opacities. So what condition can it be these days? COVID, right?
COVID.
This child turned out to be positive COVID. That this was underlying lung disease he already had. Sorry about this one, how it went upside down. But you can see the herniating bowel.
Yes,
right?
yes.
And it is bilateral. You see over here also, there is this lucency overlying the left side also.
Yes.
So this was bilateral inguinal hernia, but of course the right one was obstructing and causing strangulated hernia.
Right. Thank you, ma'am. Thank you very much.
You're welcome.
Madam, there are a few questions.
Yes, sure.
Regarding the congenital lobar emphysema, somebody is wondering, was there anything wrong with the right clavicle?
No.
Okay.
This is, if you're talking about this,
Yes, I think
this is
so.
probably some rotation there. And
True.
this always comes end on like this.
Yes.
This area where there is the curve on the clavicle, it comes end on like this.
Right.
If there is rotation.
Another question is that how to differentiate this congenital lobar emphysema from foreign body aspiration on X-ray?
Okay, good. The ones I've seen, they are usually hyperinflation, because when the the right main bronchus is more straight and it is shorter, and usually the foreign body runs into the right main bronchus or the bronchus intermedius.
Right.
So I haven't seen a foreign body going backwards into the upper lobe bronchus.
Right.
Right? It always goes to the lower lobe bronchus or to the intermedius, and then the whole lung would be hyperlucent, right?
Yes.
The whole lung is hyperlucent. You won't see
Yes.
a part of being compressed there.
Yes.
Right? And I don't think there is so much mediastinal shift. I haven't seen yet so much mediastinal shift with a foreign body. Okay? Am
yes,
I clear?
Yes, ma'am.
It won't go to the upper lobe bronchus. You see that the upper lobe bronchus arises from the right main bronchus superiorly. The foreign body would go down, right?
Yes. Then the tuberculous dactylitis case, somebody saying, can we add DD of sickle cell dactylitis in addition to spina ventosa?
For that, you have to see the rest of the bones as well.
Yeah.
Right?
Yes.
The rest of the bones appear quite normal.
True.
Right?
Yes. Then somebody has asked, I think the one of LCH case, that why not lymphocytic interstitial pneumonitis, ma'am?
Lymphocytic interstitial pneumonitis, would that give cystic lung disease?
I'm not sure about, maybe it does, but does it occur
And
in a pediatric
that comes
case?
in, that doesn't give a cystic lung disease. I don't remember myself reading this differential in cystic lung disease.
Okay.
And another thing, the differential that was given was cystic fibrosis.
Yeah.
No, cystic fibrosis would also not cause a cystic lung disease. That would cause bronchiectasis and thick wall bronchi, which we would see some tubular and some end on with signet ring appearance, right?
Yes.
But interstitial pneumonitis, you are saying, right?
Yeah, LIP.
LIP, no, that won't give such an appearance. I haven't seen such cysts in, and then the typical peripheral opacities are not seen in that.
Right.
The ground glass haze is seen, but that is more like a mosaic, I think.
Right. Somebody has said diagnosis of chest CT. I don't know. We had multiple chest CTs, so I'm really not sure which one they're talking about. If this is the one, then you have already explained, I guess. Somebody said, can it be just congenital pulmonary cysts, madam?
Congenital pulmonary cysts, yes, can be. I've seen them. They usually occur in the apical regions, right? Yeah. And then these opacities won't be there. They usually are in the apical regions, and they are usually medially placed. And I haven't seen them interspaced, uniform in size, and like involving the whole of the lung.
Right. Then somebody's asking, why not do a barium study in a dilated bowel? I guess because you showed us the hernial orifices with bowel loops. Yeah. That's why. Otherwise, we would have
in
gone
a dilated bowel.
Yes.
If we are suspecting obstruction, the surgeon won't like us to have the bowel all filled up with barium. And if it is obstructive, if it is mechanical obstruction, then the barium will cause all the more obstruction. Right? That it can cause impacted barium. I've seen one patient in my life coming with that. That was not an obstructed bowel, but still it became an impacted bowel with barium, because causing obstruction after the study, because the patient didn't drink enough water, and then the barium was all impacted in the bowel, and it caused obstruction. We don't, we can do a gastrographin study for obstruction, yes, or like non-ionic contrast we can use to find out the level of obstruction. But if there is so much bowel dilated, and of course we saw the hernial orifices, and on palpation, even the clinician must have, if he palpated the child, must feel the hernias going into the groin.
Yeah. Somebody wrote any butterfly vertebrae. I don't know if she's talking about the inguinal hernia case, but I think if it would be, madam would have told it. Why can't that be a PCP, madam?
This one?
I'm assuming that she's talking about this one.
Yeah. PCP is more like perihilar, right? It is not like so much peripheral. PCP is more like perihilar, and PCP in our part of the region is like a bit not commonly seen. And this patient had a positive PCR. Of course, differentials are considered, and that is how we rule out and make diagnosis.
Right. Somebody asked, in foreign body, can we have atelectasis rather than only ball valve?
Oh, yes, of course. I have seen patients just coming with chronic cough sent to us from the OPD because chronic cough is not getting resolved. And a radiograph was done, which probably didn't go through the eyes of the radiologist, and somehow more over here, we are still on film radiology. It is not a filmless radiology still. So that patient had a radiograph in his hand and was sent for CT chest because his chest infections and cough didn't resolve. And when we did the CT chest, it was a piece, a metallic piece, which he had swallowed of some toy, like maybe few months ago, and it was in his right bronchus intermedius, and it has caused collapse of the right middle and lower lobes.
Right.
Yes,
I think this would be, we would make this the last question, that should we mention ultrasound scan as the next step in hernia or clinical examination by surgeon?
I think this film had a very obvious hernia, and this should be a clinical examination by the surgeon.
Right, madam. Thank you so much. Again, a wonderful selection of cases, madam. We'll go to our next candidate, fourth candidate, Dr. Saneej. Go ahead.
Can you hear me?
Yes, we can hear you loud and clear.
Okay, this is a 6-year-old child with chest infection. This is his chest radiograph.
Yeah, this is a radiograph of chest of a 6-year-old child with chest infection. So I can see the bones are grossly abnormal. I can see the anterior end of the ribs are expanded and bulbous, and I can also see the humerus is grossly abnormal with expanded metaphyseal region and some lucencies and fractures. And I can also see the scapulae are also abnormal. So clavicle also abnormal. So it's a diffuse increased bone density and also multiple fractures. And in a patient with recurrent chest infection, I'm looking at the lungs. I can see the lungs are almost clear. The hyla are normal. I'm not seeing any confluent consolidation or any signs of collapse. The cardiomediastinal contour appears normal. I'm looking at the below the diaphragm and other. So in summary, so in this patient, I'm seeing a diffuse bone abnormality with increased bone density and expansion of anterior end of the rib, and also diffusely abnormal metaphyseal region of both humeri with multiple fractures. So I will see whether this patient has any previous films and also look at the clinical history and also see if there are any other skeletal radiographs available. So with this, I am thinking the possibility of any metabolic bone disorder or any it can be rickets with bulbous anterior end of the ribs and widening of the junctional zones, widening of the and also the multiple fractures. but I'll discuss with the referring clinician, and I'll also see whether this patient has any other bone disorders like osteoporosis or any like that, but I'm not seeing other features. So I would discuss with the clinician, and we'll order a skeletal survey and metabolic screening.
Okay. So this is a developmentally delayed child now.
So this is a single static image of brain of a developmental delay patient with a baby with a developmental delay. So I've been given a single axial section in a brain window where I can see the ventricles are grossly dilated. I can see the frontal horns and also part of the atrium, and I can also see the posterior fossa. There is a large cystic lesion in the posterior fossa. I can also see the third ventricle is also a bit dilated. So in my usual practice, I'll see the rest of the sections of the brain and also in MPR if available. So here there is a large cystic lesion involving the posterior fossa that is causing elevation of the tentorium, and that is also causing compression of the brainstem. And there is secondary obstruction of the fourth ventricle, causing upstream dilatation of the ventricles above, like third and lateral ventricle. So I'm thinking the possibility of a just I'm not getting the name. It's a common name. Sorry. Dandy-Walker Dandy-Walker spectrum with posterior fossa cystic lesion. So I will discuss with the referring clinician and refer this patient to the pediatric neurology for further evaluation.
Along with the posterior fossa cyst, what else do you find in the posterior fossa? Is any other finding in the posterior fossa along with the cyst, which occurs in Dandy-Walker?
Yeah, there will be vermian agenesis, like there will be cerebellar hypoplasia with vermian agenesis.
In this case?
Yeah, I forgot to mention that there is vermian agenesis, and I think the cerebellum is also being compressed and hypoplastic.
Okay. Another 4 years old developmentally child with seizures.
4-year-old child with a developmental delay and seizures. I have been given a single axial section of MRI brain, which is T1 weighted images. So I can see a midline T1 hyperintense lesion in the interhemispheric fissure, and the ventricles, and I'm looking at the ventricles and the sulci. So in a midline T1 hyperintense lesion, this could be a fat lipoma is a possibility. So in my usual practice, I'll always see whether the corpus callosum is normal. So here I can see a tubular shaped lesion, that is lipoma, that is overlying the corpus callosum. I cannot see the posterior body and splenium of the corpus callosum. So it is a partial corpus callosal dysgenesis with the corpus callosal lipoma. So in my usual practice, I'll see all the sequences to see whether any associated abnormalities like migrational disorders, like any polymicrogyria or any Schizencephaly or any other migrational disorders. And I'll also see the posterior fossa and rule out any other posterior fossa or any midline malformations. And I'll discuss with the referring clinician and arrange for a pediatric neurology referral.
Okay, good. This is another case. So the next is 10 years old with fatigue and weakness.
10-year-old child with the fatigue and weakness. I have been given a radiograph of the chest and upper abdomen. So I'm looking carefully, systematically. I can see the right lung is relatively loosened in a patient with the fatigue. And I can also see, I'm looking at the cardio-mediastinal contour, and this is not an ideal position to measure the CPR, cardiothoracic ratio, but I think the heart appears a bit enlarged. And I'm looking at the costophrenic angle. The left costophrenic angle is normal, but the right costophrenic angle is also, I think, normal. and I'm looking at the bone and the hila and the ribs. And also retrocardiac region, and I think the left hila looks a bit prominent. So this patient with the so I'm not seeing any obvious findings. Like, so I'll see if there is any lateral views available or any previous films for comparison. And I forgot the history. Like it was.
The history was fatigue and weakness. Remember?
Yeah, fatigue and weakness. This could be due to
You
any.
said the heart appears a bit large. So
Yeah,
what else would you
so-
look for?
So
in
I'll see the vertebrae for any H shape or something, and also see. I'm not seeing the vertebrae clearly, and the bones looks a bit osteopenic and gracile. So this can be a hemolytic anemia, maybe a sickle cell anemia. But I'm also looking at the humerus head and also looking at the splenic shadow, and so this can be I'll arrange for a echo to look for any cardiac anomalies, and also look for and arrange for a hematology panel to look for any hematological disorders like sickle cell anemia or thalassemia or like that.
Okay.
Okay.
This was the CT scan patient.
So this is a CT scan plain serial axial sections, selected images at the tracheal bifurcation and also at the level of four-chamber view of the heart. So I can see the heart is enlarged, and I'm looking at the mediastinum for any. I think there is a subcarinal there is some subcarinal soft tissue, but I don't know whether it's a lymph node or any. I'm looking. I can see that interventricular septum here, but and there is some dilatation of the left ventricle, and so if there are any contrast enhanced images available, I will look at the contrast enhanced images before. And I can see also the bone is also expanded, and the posterior ribs are expanded, and there is some like extramedullary hematopoiesis like picture coarse grace appearance. So this could be a hemolytic anemia with extramedullary hematopoiesis. So I'll see the rest of the series like lung window and also the bone window, and also look at the previous images, and we'll discuss the referring clinician and arrange for a hematology referral.
Okay. This is the skeletal survey of the patient.
So these are the selected images from the skeletal survey.
This chest is another patient. Okay, but this rest is the index case.
The skull, AP, and lateral view, I can see the expansion of the diploic space with the heron end-like appearance, which is a typical of thalassemia or other hemolytic anemias. And in the hands, I can see the bones are also loosened, and some trabecular markings are coarsening of the trabecular markings, and there is some expansion of the metadiaphyseal regions. And in the tibia, both femur also, I can see some expansion of the metadiaphyseal region. And in the chest radiograph of another patient, I can see cardiomegaly, and bone density is increased, and there is some expansion of the anterior and posterior end of the ribs, and also the humeral head is also looking coarse. So these are all. So these are all features of a chronic hemolytic anemia with extra medullary hematopoiesis causing bone changes and cardiomegaly in a patient with tiredness and.
Okay. So a male child involved in RTA.
So this is a CT.
Just a moment. Let me put up the. Can you see this now? Can you see my screen?
Madam, you have to share it again.
Okay, okay. Okay, can you see it now?
Yeah, I can see it. So this
Okay.
is a CT of chest of a patient coming with a road traffic accident. I can see the endotracheal tube. Sorry, I can see a tube that is here, and there is bilateral pleural effusion, and there is a that is a nasogastric tube. Sorry, and that is I can see. I'm looking at the non-contrast images where I can see some free fluid in the abdomen. The GB is distended. I'm looking at the there is some free fluid in the abdomen, and I'm looking for any cause of the free fluid. There is some cystic lesion that I think it's a bladder. Urinary
So
bladder.
what would you want to do now?
Yeah, that is that is thickened, and the wall is thickened, and there is some. So I'll see whether there is any bone. I'll see the bone window for any fractures. So and
Okay.
also I would like to see whether there is any urinary bladder injury. I would like to see contrast.
So on this image, can you see anything?
Madam, I didn't hear you. Yeah, I can see the multiple fractures of the pelvis.
Mhm.
So in a multiple fracture of the pelvis, so we have to suspect any intraperitoneal or extraperitoneal rupture of urinary bladder,
I
which we
scroll
can
down
see.
again for you.
So this is
the
the
post-contrast.
bilateral pleural effusion, basal segment atelectasis. There is spleen. I am looking at the spleen, but this is I can see the free fluid in the abdomen again, and I'm looking at the bowel. There is no bowel dilatation. I can see there is again. I can see some wall thickening.
This was post-contrast, right? You found
And
pelvic
I'll see
fractures.
I'll see any delayed images, or also I'll see whether there is any cystogram or CT cystogram is done.
Yes. So these are the delayed images.
So in the delayed images, I can see the kidney, both kidneys are excreting contrast, and I can see the contrast in the pelvis. So the ureters are partially imaged, and I can see them contrast leak in the peritoneum, intraperitoneal leak, and I can see the contrast in the urinary bladder also. So the contrast, that is intraperitoneal rupture of urinary bladder with multiple pelvic fractures. So this is an emergency, and I can see the Foley's bulb in situ. I can see multiple fractures here again. So I'll confirm it in the bone window, and I'll complete the study by looking at the lung window also. And also I'll inform this to the referring clinician in the emergency department, and we'll arrange for an emergency urology and orthopedic referral and for this patient.
Okay, since we'll have to come back to it, so I just tell you about it. You are right, there is bladder rupture, but it is a combined bladder rupture. You see this in the right paracolic gutter, which is intraperitoneal fluid. And when the peritoneal fluid is in the, the contrast is in the perivesical space, it is extraperitoneal rupture, right? So this was a combined urinary bladder rupture with multiple pelvis fractures. Okay.
So I was about to tell, but I was not aware of a combined thing. Sorry.
Okay. Can you see the screen now?
The other screen. 1 second. We have to stop sharing this. And okay.
Okay.
Now
Okay. So you can see now.
We would make this the last case.
Okay. So we are done with them.
No, if you have another case, we can go ahead, but that would be the last.
Okay, I'll tell you the previous ones here, which we just saw.
Sure.
This one, yes, this is rickets, but these are not fractures. These are pseudo fractures, right? The insufficiency fractures. And you rightly said the epiphyseal plate is white. There is some bone density is reduced as well. And this abnormality is called
Rackety rosary.
which you should mention as well. Yes, this was Dandy-Walker malformation. And you can see the cyst communicating with the fourth ventricle. And vermis is absent and cerebellum is hypoplastic. Very rightly, this one was very well done. This is another case in which you can see another lipoma and a partial agenesis of corpus callosum. This you should have picked. There is some paratracheal or paravertebral stripe there. The ribs are expanded posteriorly. You should have picked up this, right? And you know, our teachers told us that when you see, normally the 1/3 of the heart should be towards the right of spine and the rest of 2/3 towards the left. And this diameter should be like on just seeing the film, right? This was what our teachers used to say, a rough idea. It should, if the heart is normal in size, we should see the lung lucency equal to the width of the heart on the right side. But here on the first look, this lung lucency here is very less. And so this was heart enlarged. And of course, this was thalassemia with extramedullary hematopoiesis. And this is the Erlenmeyer-Flass deformity of the humeri. And you can see the bone is infiltrative, permeative pattern of bone abnormality, the hair-on end appearance. And this was the... Okay, this is another case. Anyone who wants to volunteer to describe this, or should I just go through?
No, doctor, we do have a backup, Dr. Ali. I think he can take the case.
Now, we still have like half an hour to go.
Yes, yes.
You want to try?
Yes, Dr. Ali, can you unmute yourself?
Can you hear me?
Yes, we can hear you.
Okay.
Over to you.
Okay. So this is a hand radiograph, frontal projection of skeletally immature patient. I can see there is acroosteolysis involving the distal phalanges. Also, the bones appear dense. I cannot see any soft tissue calcifications and no evidence of fractures.
So what would you want to do next in your clinical practice?
In case of generalized bone density with acroosteolysis in a child,
yeah.
I am thinking of can be an osteoporosis.
Would you like to do anything else for this patient?
I would like to check the previous hand or any other bone, any other radiograph available for another.
Okay, there is no previous present. Would you like to do anything for the patient? This patient came with short stature.
So if it's short stature, I would think about pycnodystosis. So skull radiograph will be helpful to looking for the mandible, especially wormy and bone.
So this patient had this these radiographs done.
Okay. So
any particular finding that would favor pycnodysostosis?
Yeah, there is in skull radiograph, lateral skull radiograph, I can see the abnormal angulation of the mandible. Also, I can see the wormian bone posteriorly. So that in keeping with pycnodystosis.
Very right, very good.
Yes. On the spine and that abdomen and the pelvis, there's generalized bone density. That's also in keeping with osteoporosis.
Yeah, you don't see the bone within bone appearance. You don't see the vertical striations, lucencies in the metaphysis. And this is the obtuse angle of mandible. and the Vermian bones and the acroosteolysis, which is seen in pycnodysostosis and not in osteopetrosis. Sabahat, if it's okay, I'll describe the films right away as we go on.
Okay, madam. Okay, madam. As you wish.
So this was our differential. In this was the osteopetrosis, lateral skull. You can see the angle formed very well, and you can see the obtuse angle in pycnodysostosis, right?
Okay.
So another case of abdominal distension in a neonate.
Okay. So this frontal radiograph of neonate with abdominal distension. I can see there is dilated bowel lobes. Also, I can see the wall of some of the bowel lobes that are presenting regular sign, which indicating pneumoperitoneum. Also, there is a football sign that generalized air lucency surrounding the whole abdomen. Also, I can see linear lucency over the liver, which indicating portal venous gas. So I'm just looking for any specific area of pneumatosis in this child. It looks like in the left lower part of the abdomen, there is some pneumatosis. So in neonate, this most represent necrotizing enterocolitis with perforation. And this is an emergency that needs urgent surgical intervention. So I would call the surgeon about the pediatrician about the finding for urgent pediatric surgery intervention.
Okay, that's good. I don't know how these my films have flipped. I must have done something wrong there. But this was another case which showed this bowel wall air. If you allow me, I'll just put it right for you. Just a moment. I'll share the screen with you again. Okay, so you can see this, right? You can see the bowel air in the on the left side in this
Yes.
case. This was like no perforation as yet, but you can see these linear lucencies in the bowel wall. And there's no air at this point in time. The bowel is dilated and it is filled of air right up to the rectum. And this has ileus and this has this air in the bowel wall. So we should be able to detect these cases earlier, right?
Yes.
So this patient has bleeding gums.
Okay.
The radiograph is not very good, but still we can see whatever is required.
Okay. So
If
this
you
is
can describe.
this is a frontal radiograph of an immature, skeletal immature patient of both knees. I can see there is generalized reduced bone density. Also, there is sclerosis line along the metaphyseal area of the both femori. Proximally to it, there is also a lucent line proximally to it. So those lines are also seen, but less extent in the proximal tibia. There is also a well circumscribed cortical along the tibial epiphysis. So all those signs that indicating that maybe scurvy with this child, especially with the bleeding per gum. So that sclerotic line is zone of provisional zone of sclerosis. Radiolucent line is Kramerfield line, and Wimberger sign, that's the dense, well-defined density along the epiphysis of the tibia. Also, I can see some periosteal elevation along the distal left femur that may indicating subperiosteal hemorrhage. So this findings are in keeping with scurvy. I would like to check the ascorbic acid levels on the child and convey this to the pediatrician.
Okay, good. This was scurvy and all the signs with it, right? So a neonate with respiratory distress.
Okay. So this is chest and abdomen of neonate with respiratory distress. I can see there is endotracheal tube, which is in position. Both lungs appear reduced in volume. And I can see also there is some haziness and granularity along both lungs. Also some air lucency within the lung interstitium. Also I can see. I'm just looking in the abdomen if any abnormality which I cannot see. The bone appear normal. Both humeral heads are not seen, so this may be a mature child. I'm just looking if there is any pneumothorax that, but I cannot see actually. So in this case, my primary diagnosis is respiratory distress syndrome in a premature child, and with probably complicated with pulmonary interstitial emphysema due to oxygenation. I just will check if there is any previous X-ray for this child available, and also convey the message to the pediatrician.
Okay, this you're very right. This is pulmonary interstitial emphysema, but you see this streak of air over here,
Yeah,
and a
yeah, I
streak
saw.
of air over here. Yeah, this was bilateral pneumothorax as well. And you very rightly said this is a premature child, and even the air has not reached into the whole of bowel as yet. So this was RDS, and probably due to the ventilation and high pressure, they've introduced more air and pneumothorax. And now this child presented with coarse facies.
Sorry, I didn't saw the history.
Coarse facies. The facial features are coarse.
Also, though I'm presented with limited view of the abdomen and chest or spine, the spine view of dorsolumbar spine and the part of the pelvis. I can see there is the both femoral epiphyses appear fragmented and small. Also, I can see the small pubic, small iliac bones. I'm looking for the vertebra. I cannot. This could be there is. No, this looks fine. So the vertebra, it looks fine. Maybe occult spina bifida in the sacrum there. The bowel shadow, it's okay. The cardiac size appear normal. Ribs looks normal. So the main abnormality I can see is the abnormal segmentation of the femoral head. So my differential diagnosis will be Hypothyroidism can lead to that. Can some congenital dysplasia also can cause abnormal segmentation of the head. I would see if there is any available joints X-ray available for this child to see if there's generalized epiphyseal abnormality or only to the femori.
So you would want to do like a skeletal survey or something?
Yeah, if there is skeletal survey, that's good. Okay, for another joint. Okay, so this is lateral X-ray of the dorsolateral spine. I can see there is posterior scalloping of the lumbar vertebrae. Also, there is an anterior peaking, inferior anterior peaking of the lumbar spine. In the wrist X-ray, I can see there is mid-lung deformities, which abnormal angulation of radioulnar joints. Also, the bones appear slightly tapered distally. The metacarpals appear tapered distally. So, keeping all those findings together, this looks like mucopolysaccharide disease.
Okay. If you see this radiograph, these ribs are O-shaped ribs.
O-shaped, yes.
Right?
Yes.
And this acetabulum is so slanting. Huh? This is typical of MPS. And then both the proximal epiphyses are small and irregular, which mostly occurs in Marquis type. But in our case, this was inferior beaking. And there is proximal tapering of the metacarpal slanting and mid-lung deformity of these ulna and radius. And the differentials, if you see bilateral epiphyseal, capital femoral epiphyseal irregularity, of course, the differentials would be epiphyseal dysplasia, Marquis, or MPS, or hypothyroidism, or bilateral AVN, right? You are very right with this. So this is another case of swollen left eye with closure of lid.
Okay.
Okay, this one I have to scroll. We will scroll through. Sorry. This is. Okay, this is the case. Okay, can you see it now?
Yes, I can.
Okay, first we'll do the. We'll do the soft tissue window. Sorry. Okay.
Okay.
So I scroll for you.
So this is soft tissue window plane study, I think.
Sorry, let me adjust the window first. We'll start with this.
Okay, so bone window. I can see now there is some lytic lesion along the left maxilla with thinning of bones. So I saw lytic lesion in the maxillary area.
Okay.
Okay, soft tissue window. Yeah, so inside that lytic lesion, there is hyperdense area anteriorly and hypodense posteriorly. Extend to the left ethmoid bone. There is dehiscent of lamina papyracea on the left side. Okay, that led. There is some soft fluid collection there in the preseptal region of the left eye. Also, I can see
Fluid collection where?
just medial to the left orbit, medially.
Okay, okay, yeah.
And there is soft tissue components within that collection anteriorly. Yes, this one.
What do you think this is going? What is going on there?
Sorry?
What is going on there?
So I'm suspecting some sinusitis with extension, periosteal collection and extension to the preseptal area of the left orbit and to the eyelid,
Okay.
causing that.
Okay.
Just if there is contrast available just to roll out any enhancing mass there. Otherwise, clinical
This
correlation.
hyperdense area. Okay.
Yes.
And let me, you're talking about this as a mass.
Yes.
Anything else in the sinus with infection?
This can be also this hyperdensity due to chronic sinusitis with fungal infection causing that hyperdensity.
Yes, yes. And this
So
had
can be an
actually involved the
invasive
adjacent bone as well, which
Mhm.
is sclerosed, and there was chronic osteomyelitis of this bone as well. And it had extended into the left orbit. You can appreciate the thickened, in comparison to the right one, the thickened muscles, the thickened optic nerve, and of course there was a small collection of fluid there also in the preceptal space medially. So this was
Invasive fungal.
chronic infection of the sinusitis, and along with involvement of the orbit as well.
Madam, the 15 minutes for this candidate is over now.
Okay, should I just go through a few more cases and then
That would be perfect, madam. Yes.
Okay.
Thank you, Dr.
So this is a CT scan abdomen. I hope you can appreciate these
Yes.
lucencies, mottled lucencies in the stomach going along it to the pylorus. And this is the coronal and the axial image. These lucencies are passing into the duodenum towards the left side into the jejunum. You can see these here. So this could be a bezoar, right? This was a subnormal patient, and she used to eat her hair. And then one day she presented with vomiting. Another crying neonate. You see, this is very typical. Bone density is reduced. So many fractures. And this was osteogenesis imperfecta. Another short-statured patient. Sabahat, you want to try?
Okay, madam. So
This is an interesting case.
Yes, this is the AP view of the right hand of a child, and I've forgotten the history already. What I can short stature, yes.
Yep.
So short stature, but I can see that there is fusion of the metacarpal. Actually, there is an 1, 2, 3. There is an accessory finger.
Yes.
With fusion of the two metacarpal bones. And the patient is short-statured, and this is I think classic for some syndrome,
Yes.
which at the moment I cannot recall that.
Okay, you're very right. You're very right. These metacarpals are short and stubby. There is fusion of the supernumerary. This is post-axial extra digit, right? This is on the ulnar side, and there's fusion of its and the fifth metacarpal. The capitate and hamate are also fused. What would we do next in the clinical practice?
In the
If
skeletal
we
survey,
think of a syndrome.
the skeletal survey.
Yes. And so this patient had this hypoplastic tibial epiphysis, right?
Right.
And if I say the patient had like coarse hair and nails and the teeth were abnormal, so what comes to your mind?
Turner's?
Ellis Van Creveld syndrome.
Ah, yes, yes.
Right. Chondroectodermal dysplasia.
Perfect,
Right?
madam. Yes.
And another syndrome that would give a polydactyly is Carpenter's, right? But then that would have an acrocephaly, a towering skull, right?
Right.
Okay, this one is bilaterally small, highly placed scapulae,
Yes.
sprengles, and omovertebral bones articulating with them. So these have associations, right?
Yes, madam.
This is a barium follow-through study, and this is malrotation. We can't see the duodenum going towards the left of spine, right?
Right.
And this is another malrotation, the duodenum third part here, and this is with volvulus.
Yes.
It didn't go to the left of spine, and it should be at the level of duodenal pulp, right?
Yes.
And this is with the
corkscrew
appearance. This is what diagnosis? This is like a barium follow through, dilated part, dilated, multiple strictures, rose thorn ulcers there, rose thorn ulcers, pseudo diverticular formation. This was Crohn's.
Yes.
We do see Crohn's in this part of the world also. In fact, we have quite a number of children with Crohn's. This is another barium follow through, dilated bowel there, terminal ileum narrow, and the cecum is abnormal, deformed, a bit higher in place. So this is tuberculosis. Yes. In TB, we won't see the multiple strictures, right? We won't see the pseudo-diverticular. Typically, the terminal ileum and cecum are involved. In Crohn's, the cecum is involved first, and then the terminal ileum. This is another tuberculous patient with deformed cecum and narrow terminal ileum. This is an MCUG study. We can see the catheter there, and this is reflux into a cross-fused ectopia.
Yes, perfect case, madam. Very nice.
This is
hyperintense
water spats disease.
Hyperintense.
Okay, so that's it.
Thank you so much, madam.
I hope it did benefit you. Sorry for the few. I don't know how it happened.
No, not at all, madam. Madam, the last case people are asking again, the hyperintense globus pallidus. People could not hear the diagnosis. This one, yes.
Okay. I'll show you the DICOM for it. So you know, if you see the coronal images, that would be better, right? Just give me a few moments.
No problem, madam. Take your time.
Let me take out that case. And
madam, we should have an examiner like you on our exam day.
Oh, this was like helping you all. Otherwise, I'm quite a strict examiner. People say, oh, we don't want to go to Dr. SAIRA. Just pray she doesn't come. But if a candidate is good, if a candidate is good, then I really help that person. But if you know that the candidate is, has not done his work properly in the training period, then,
it shows.
No one can help that person.
Yes.
But all our candidates were quite good, I tell you, Sabahat. I was so happy listening from them.
Thank you so much, madam.
Can you see the?
Yes, T2 axial. Yeah.
Yes, T2 axial images. You can see the globus pallidus are hyper intense, and if you see the coronal images for this, this one. Okay, this is the typical tiger eye appearance.
Yes, madam. True.
And the surrounding hypointensity and the internal hyperintensity. Haller-Warden-Spatz disease.
Yes. Wonderful, madam. Wonderful. Just if I can ask, if somebody asked that, what should be our approach to pediatric x-rays with increased bone density? Like, how should we be proceeding? Only if you can give a short.
Yes, you know what? Common things first. First is osteopetrosis.
Yes,
Pycnodysostoses, I have seen a number of cases. We do see on and off, but that should be mentioned in a differential. Other is myelosclerosis, even sometimes, not the other myelosclerosis, but like sometimes these things can give increased bone density, right? But we don't see them so often. The other thing is fluorosis. We do see in this part of the world, but rarely. I have seen a few cases in my career, but mostly that they come are with osteopetrosis. Mostly we do see them on and off. And then by hypervitaminosis D, we see them renal osteodystrophy. Yes, I've seen them with sclerosis, bone sclerosis. But then in those cases, you will see the rickets changes also very well. If you see a radiograph with bilateral nephrocalcinosis, then you can always think of renal osteodystrophy lying somewhere in the rest of the bones, or a Brown's tumor, or pathognomic changes in the hands of hyperparathyroidism, or a Rutherford spine,
Yes, yes. True.
Anything else?
No, madam. Now people are just thanking you. It was a great session, madam. All the cases were so classic. Especially the mucopolysaccharidosis case was very nice. I don't know if it's possible. Somebody's asking to go back to the Wormian bones.
Those were a very few. Those were a very few, no doubt. But they were there. Let me see if we can find them somewhere there.
If it's easily possible. Otherwise, it's okay, madam. What are the contraindications to barium enema in a child? Somebody's asking that.
To barium enema in a child. You see, it depends. Of course, we do a plain radiograph always for these patients to see if there is any dilated bowel, right?
Right.
And we don't do that, of course. And if there is, like I said, if there is like so much obstruction, or there is ischemic bowel, we can see a toxic megacolon. Of course, we won't do that.
Yes.
But usually the patients that come for barium enema are those with chronic constipation.
Yes.
And we don't do the full protocol for those patients. Can you see the screen?
Yes, we can. The differential of osteoporosis and dysostosis.
Okay, this is one Wormian bone. This is another Wormian bone. This is another Wormian bone.
True, true.
I did have Wormian bone. If you want to see, I can show you.
For sure. I'm sure you have a treasure of images. Somebody has also asked that if I think that in suspected perforation also, of course, will not go for barium enema, right, madam?
Of course, that is why I always do a plain radiograph for whatever study I'm doing on fluoroscopy.
Yes.
because that gives you so much information. Even afterwards, for comparison, you can go to the plane and see whether you're seeing some artifact or you are seeing something that was already there. You see?
Yes, yes, ma'am.
Okay, so
Yes,
thank
madam.
you so much.
Thank you so much, madam. It was a wonderful session, and thank you so much for your time and your kind words and your kind time and cases. Everybody enjoyed it so much.
I hope so. And thank you everyone for attending my session. And thanks so much, Sabahat. And we always learn from each other.
Pleasure,
Okay.
madam. Pleasure.
Okay. Bye-bye.
Okay. Bye, madam.